Hello, my name is Tonya Hunt. This is the presentation of my Doctor of Nursing Practice project titled Quality Hospice Care, Improving 3 Quality Indicators for Patients at End of Life. In this presentation, I will introduce the ideas that sparked this project, the significance of the project ideas, the study methods, its results, strengths, weaknesses, implications for practice, and implications for future research. I would like to acknowledge Dr. Gail Petroff, my DNP Project Committee Chair, Dr. Gangadeep Singh, my community member, and Dr. Mark Powles, Maryville statistician, for their help and their support. To begin, the idea for this project stemmed from both a professional and a personal level. Professionally, I am currently the Director of Clinical Services at a hospice and palliative care company in the Midwestern United States. In this role, I focus on the quality of end-of-life care being provided to patients and families. So what is hospice care? According to the National Institutes of Health, to qualify for hospice care, a person needs to have a terminal illness and they must have a life expectancy of 6 months or less if the disease process were to continue without aggressive treatments. The Centers for Medicare and Medicaid help to regulate the quality of care provided at hospice agencies. The Hospice Quality Reporting Program, or HQRP, gives a standard for quality measurements for hospice programs. Another way to measure the quality of end-of-life care is through the Consumer Assessment of Healthcare Providers and Systems Survey, also known as CAHPS. It is issued to the primary caregivers within 2 weeks after the patients have died. It helps to measure their understanding and the comfort that they had in caring for their loved ones at end of life. At the project site, it was noted that the 3 quality indicators of pain, respiratory, and bowel management were assessed at 100% on admission for the HQRP. However, in these 3 areas, they were low on the CAHPS survey scores. The question then formulated of whether or not these scores could be improved. On a personal level, my father-in-law, who was known as Pop Pop, passed away on June 13th of 2021 from pancreatic cancer. My spouse and only child spent months taking him to chemo and radiation appointments after he was diagnosed. While he was still alive, he received multiple of patient surveys that were issued wanting to know more about his patient care experience. What we realized was that amongst the 3 of us, not all of our answers were the same. We had different expectations and perspectives of what his care should be like. For his final days, he was placed on hospice services. During his last few days of life, we often found the education provided at the bedside unclear. Even as a hospice nurse, I too was overcome with grief and had a hard time remembering some of the things the providers taught. Even now, as my spouse and I look back, we remember Pop Pop, but not too much of anything else during those final days. From both my personal and professional experiences, the desire was sparked to see if the quality of hospice care could be improved upon. specifically wanting to know if the implementation of an educational tool could help improve the three quality indicators of pain, respiratory, and bowel management. The population, intervention, comparison, outcome, and time period, or PICO question, for this study was: in hospice care for primary caregivers, can the implementation of an educational tool improve the understanding of three quality indicators of pain, respiratory, and bowel management as evidenced by the improvement of CAP scores from quarter 1 to quarter 4 at the project site? The phenomenon of interest for this study is hospice and palliative care. It addresses the 5 patterns of knowing for nurses, and the theoretical framework is the RE-AIM model. According to Chin and Kramer, the 5 patterns of knowing for nurses are emancipatory, ethical, personal, aesthetic, and empiric. Emancipatory is that connection that leads to social change. I recognized there was a need to make the end-of-life experience better for patients and their families. Ethical refers to right versus wrong. For this study, I wanted to make sure the questions and training were presented in a way to not give away the answers as well as protect patient confidentiality. Personal is that self-awareness to nursing care. I feel I have been able to find a balance between the professional and personal experiences and applying that to my nursing practice. Aesthetic is that search for a deeper meaning to each patient encounter. To me, this is the heart of hospice and palliative care, finding a way to make the experience unique for each patient and family unit. Empiric is the science of nursing care. Science leads to that desire and the ability to provide evidence-based end-of-life care. The theoretical framework for this study is the RE-AIM model. RE-AIM stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. For this study, the target population reached is primary caregivers of hospice patients. Effectiveness would be if the educational tool was able to help improve those scores from quarter 1 to quarter 4 on the CAP survey. Adoption and implementation are related to the clinician education, and maintenance is supported by the governing body at the project site. An educational tool and data collection tool were created using the literature review and CAP survey as a guide. Once approval was received from the governing body at the project site, as well as by the Maryville University IRB, data collection began. Participants were not engaged, and no patient information was extracted from the surveys. There were no foreseeable physical, psychological, social, economic, or legal risk. One possible risk was a breach of confidentiality. However, this risk was minimal. CAP survey scores from November 1st of 2022 to August 31st of 2023 were reviewed. Each was given a number on the data collection tool. Here is a sample of the educational tool. It was important when creating the educational tool to make sure that the interventions were similar to the CAP survey questions, but not repeating the exact questions. The goal for this study was to improve the scores without giving anything away. Here is a sample of the data collection tool. It did include the questions from the CAP survey. The governing body provided me with a secure password to be able to electronically access the CAP surveys. The written list of surveys was stored in a locked file cabinet in my locked office. The data was collected pre and post intervention. All collected data for this project will be destroyed 3 years after the completion of this project to further maintain confidentiality. The education related to this study was presented to the staff at the project site. They were given the opportunity to volunteer to use the educational tool. All surveys during the period of November 1st of 2022 to August 31st of 2023 were reviewed. Additional inclusion criteria were the clinicians needed to be employed at the project site, and they needed to be a nurse that provided direct patient care. Exclusion criteria were clinicians who were not employed at the project site, and they were maybe clinicians who provided direct patient care, but they were not nurses. For this study, nurses were needed due to the medication aspect of the educational tool. Once the data had been collected, assistance was received from Maryville University statistician Dr. Pauls. The statistical package for the social sciences, or SPSS, was used for the statistical analysis, and a Mann-Whitney U-test was performed to compare the mean ranks and sum of ranks of the CAP scores pre and post intervention. The independent variables were the time before and the time after the intervention, and the dependent variables were the CAP survey scores. For the analysis, the statistical power was established at 0.8 or 80%. A minimum of 102 surveys were needed. However, for this study, a total of 183 surveys ended up being reviewed. The level of statistical significance was established at a p-value of less than 0.05. The final categories were divided into pain meds, side effects, breathing, and constipation, with a comparison being made of the mean ranks pre and post intervention shown here. After the mean ranks and sum of ranks were analyzed, the z-score and asymptotic significance two-tailed were also collected. The results showed significantly significant results in breathing at less than 0.001 and in constipation at less than 0.005 post-intervention. Insignificant findings for pain meds, 0.842, and side effects of 0.596 were found post-intervention. This was a quantitative exploratory design through a retrospective CAP survey review. It took approximately 9 months to complete. From November 1st of 2022 to August 31st of 2023, 183 surveys were reviewed, 94 pre-intervention and 89 post-intervention. This study showed there is clinical significance to improving education at the bedside to enhance primary caregivers' understanding of managing breathing and constipation in their loved ones at end of life. In addition to the organizational support at the project site and that of Maryville University, there were some additional strengths to this study. The first being the CAP survey process itself. It's the same every time, which led to minimal deviations that could sway the results. The validity and reliability of the data collection tool facilitated the statistical significance. The clinicians being allowed to volunteer to use the tool was also a strength, as they were the most engaged. 102 surveys were needed to reach a statistical power of 0.8. A total of 183 surveys were reviewed, which helped to strengthen that power. There were some weaknesses and barriers, with time being the first barrier to this study. There were some unexpected systems delays that led to a delay in the survey results being processed over the summer months. This led to a change in the overall study's timeline. The period to start collecting the data post-intervention was shortened. Initially, it was going to take a year to complete this study, and instead it was shortened down to 9 months. An extended period would have given the clinicians more time to improve their practice. Another weakness was there were a few nurses who resigned from the project site mid-study, and they were known to have been using the educational tool. There was also not continuous contact with the volunteers who were using the educational tool over the course of the study. The focus really did stay on the CAP survey scores itself. If additional time had been spent checking in with those using the tool, this could have helped enhance the study results. An unexpected positive outcome of this study, while not officially tracked, was the overall hospice satisfaction rating at the project site did improve after the intervention. The idea for this DMP project stemmed from a professional as well as personal level. Its foundation includes the 5 patterns of knowing for nurses and the RE-AIM model as the theoretical framework. The results of the study show that there is clinical and statistical significance for addressing the 3 quality indicators of pain, respiratory, and bowel management, with specific clinical significance to improving primary caregivers' understanding of respiratory and bowel management in their loved ones. While there was no statistical significance in the areas of pain meds and side effects, there was still dedicated time spent at the project site providing this education at the bedside. For the future, there is support for providing continuing education while the patient is on hospice services. This provides enough time for feedback and further explanation as needed while the patient is still alive. Sustainability will involve an interdisciplinary team approach. For this study, only nurses were included based on the inclusion criteria. For future, recognizing the importance of the interdisciplinary team to end-of-life care, the educational tool can be adapted to each discipline so all can use it. We all have a birth story. Hospice helps with people's death story. Recommendations of this research study are for use in enhancing education at the bedside to improve the quality of the end-of-life experience for patients and their loved ones, helping to bridge the gap between the professional and the personal of the patient and family unit. Key references for this study were CMS, NIH, Chin and Kramer, and White, Dudley Brown, and Tahar. I thank you for your time and for your support.